So if you inject like liquid plastic or permanent silicone into the highly sensitive, really vascular tissue of a patient's intimate areas, there is no biological undo button.
Right, there really isn't. You're just stuck.
Yeah. If that material migrates a year later,
Yeah.
or if it accidentally blocks a blood vessel, you are looking at a surgical emergency. The body just has to adapt to a foreign invader, and removing it requires complex, invasive procedures.
It's a nightmare scenario.
Mm.
But today, the world of modern aesthetic medicine has actually discovered a literal reset button.
Which is amazing. Welcome to today's deep dive, by the way.
Thanks. Yeah, this reset button, it completely changes the risk profile of these procedures for patients.
Yeah.
When we talk about hyaluronic acid fillers, this reversibility isn't just, a convenient feature for someone who wants to change their look.
Right, it's not just cosmetic.
Exactly. It is the fundamental, non-negotiable reason these treatments are considered safe for some of the most delicate anatomy in the entire human body.
And that sets up our specific mission for this deep dive. Today, we are exploring a highly specific question for you listening. Can an intimate hyaluronic acid or HA filler be safely retreated into the exact same tissue area after it has been fully dissolved by enzymes?
It's a great question.
Right, because we were talking about highly sensitive zones here, penile girth enhancement, labia majora augmentation. When someone gets a cosmetic filler in these intimate areas, has it dissolved for whatever reason and wants to try again, what actually happens to the underlying tissue?
Well, to get to the bottom of that, we're looking at a pretty comprehensive stack of clinical case series, pharmacological reviews, and aesthetic guidelines spanning over 15 years of biocompatibility data.
15 years. So we have a lot of evidence here.
We do, and I want to emphasize to you listening, we aren't just talking about aesthetics today. We are diving deep into tissue biology, biochemistry, and really the incredible regenerative power of the human body.
Okay, let's unpack this. Because to understand how we can safely dissolve and replace a filler, we first have to understand the environment we're working in. We're talking about penile and labial tissues. These aren't just like the skin on your forearm.
Oh, far from it. The anatomy of those regions makes them incredibly unique. They are highly vascularized, meaning they have this dense, intricate network of blood vessels.
Right.
They're also dynamic, spongy tissues that undergo, significant changes in blood flow and physical size. So in the past, when practitioners attempted to use permanent fillers like PMMA, liquid silicone, or even paraffin oil, the complication rates were severe.
Just reading the case studies from a few decades ago sounds like a horror movie.
It really does, because the human immune system is designed to attack foreign bodies, right? When it can't break down a permanent material like silicone, it just walls it off. It creates these hard, painful nodules called granulomas.
Ouch.
Yeah. Worse, if a permanent filler compresses one of those many delicate blood vessels, it can cause tissue necrosis.
Meaning the tissue actually dies from lack of oxygen.
Exactly. And removing those permanent materials from intimate tissue requires complex debridement surgeries. You're physically cutting out the plastic and the healthy tissue that's wrapped around it.
Which is obviously why the industry shifted away from permanent plastics and towards something the body already recognizes. And the star of the show here is hyaluronic acid.
Right, HA. Hyaluronic acid is a naturally occurring polysaccharide, which is essentially a very long chain of sugar molecules that lives right there in our extracellular matrix.
It's the scaffolding.
Exactly. It functions as the scaffolding of your skin and tissues. It binds to water, providing volume, turgor, and hydration. To give you a sense of scale, in a typical 70-kilogram person, there are only about 15 grams of HA in the entire body.
Which really doesn't sound like a lot of material to work with.
It's a small total amount, yeah, but the turnover rate is staggering. Your body is constantly breaking it down and synthesizing it anew. It turns over about 5 grams a day.
Wow, 5 grams a day.
Yeah, and about 50% of all the HA in your body is concentrated in your skin. Its natural half-life there is remarkably short. Like a single molecule of natural HA only lasts 24 to 48 hours before native enzymes just sweep it away.
So if a doctor just drew up a syringe of natural, unmodified hyaluronic acid and injected it into your skin to add volume, your body's biological housekeeping would clear it out in a matter of days.
Right.
It would be entirely gone before the injection site even healed.
Precisely. Which means cosmetic fillers must be biologically modified to survive that environment. If a patient wants an aesthetic result that lasts, 6 to 24 months, scientists have to stabilize that HA molecule against the body's natural enzymes.
And the industry standard mechanism for that stabilization is a chemical agent called BDDD.
Yes, BDDE.
That stands for 1,4,4-butynadyl diglycyl ether, right?
That's the one. Under highly controlled basic conditions in a laboratory, the epoxide groups at the very ends of the BDDE molecule react with the primary alcohol groups along the hyaluronic acid backbone.
Okay, so it forms a new bond.
Right, this chemical reaction forms an ether bond, and ether bonds are incredibly resilient. They can withstand the body's natural heat, its fluctuating pH levels, and they physically block the native enzymes from easily breaking those sugar chains apart.
Let me jump in with an analogy here to visualize this for you listening. I like to think of the natural HA inside your body as a pile of loose, individual Lego bricks.
I like that.
Right. Your body's natural enzymes are like a kid who can easily come along and kick that pile apart in a day or two. But BDDE acts like a chemical superglue. It cross-links those individual Lego bricks, locking them together into a solid, unyielding wall.
Exactly.
It turns a liquid that would disappear in days into a stable gel. Now, the kid comes along to kick the wall, and they can't break it.
That's a perfect way to picture it. The superior stability of that cross-linked ether bond is really the sole reason these fillers can last a year or more in highly mobile tissue. But, anytime you introduce a synthetic chemical cross-linker like BDDE into the body, the immediate question is safety and toxicity.
Here's where it gets really interesting. Because if you hear chemical superglue, you might naturally get a little nervous about having that inside your body. But the purification process for these fillers is astonishing.
It really is.
The sources note that after the cross-linking reaction is finished, extreme purification leaves behind fewer than 2 parts per million of unreacted BDDE.
Right, and to put that math into perspective, that is less than 0.0002 milligrams of unreacted BDDE in a whole 1 milliliter syringe of HA gel.
That's practically nothing.
It is a trace level so vanishingly small that it historically represented the absolute limit of our chemical detection capabilities. And when that modified BDDE eventually does degrade over the course of a year, it breaks down into harmless byproducts like glycerol and butynadyl.
Which the body just handles naturally.
Exactly. They are metabolized by the liver and eliminated naturally, yielding nothing more than carbon dioxide and water.
Okay, so we had this unyielding wall of superglued sugars that won't budge for a year. It's perfectly safe, and it provides great volume. But what happens when things go wrong?
That's the big question.
Right, if a patient hates the aesthetic result, or if the filler migrates, or worst case, if a blood vessel gets compressed, waiting a year for the body to slowly chip away at those ether bonds just isn't an option. So how does a doctor manually break that chemical superglue?
That requires a targeted biological solvent. And in aesthetic medicine, that solvent is an enzyme called hyaluronidase.
Ah, this is the reset button.
This is the reset button. Hyaluronidase specifically targets and cleaves the beta-1-strol-4 glycosidic bonds in the hyaluronic acid polymer. It just rapidly severs the connections between the sugar molecules.
So going back to the Lego wall.
Yeah, going back to your Lego wall, hyaluronidase is the chemical solvent that instantly melts the superglue. It turns the solid wall back into a loose pile of individual bricks that the body's lymphatic system can just easily flush away.
And the speed at which this happens depends heavily on the physical structure of the filler itself, right?
Yeah.
Our sources mention biphasic fillers versus monophasic fillers. Biphasic fillers apparently start softening in just 5 to 15 minutes. Why is it so fast?
It really comes down to surface area. A biphasic filler is manufactured by taking a block of heavily cross-linked HA gel and physically sizing it through a mesh. This creates thousands of microscopic cross-linked particles.
Okay.
Those particles are then suspended in a smooth, non-cross-linked liquid HA for lubrication. So because the filler is broken up into thousands of individual particles, the hyaluronidase enzyme can instantly surround every single particle. It attacks a massive amount of surface area all at once.
Right, granulated sugar.
Yes.
Yeah.
It's like dropping a handful of granulated sugar into hot tea versus dropping in a solid sugar cube. The granules just dissolve almost instantly.
Wait, hold on. If this enzyme is designed to seek out and dissolve hyaluronic acid, and my own skin is full of natural, native hyaluronic acid, are we dissolving the patient's actual skin? Doesn't the erasure melt the natural tissue right alongside the cosmetic filler?
I'm glad you asked that. This raises a very valid concern, and it's honestly one of the most common fears patients have when they hear about this procedure. The reality is that the enzyme cannot distinguish between the injected cosmetic HA and your natural HA. It does temporarily break down native HA in the surrounding tissue.
Okay, that sounds really alarming. If I'm getting a correction in a highly sensitive, intimate area, the last thing I want is for my native tissue to be melted away.
I know, it sounds severe, but we have to connect this back to the biology we discussed earlier.
Right.
Remember, your body naturally produces and turns over 5 grams of HA every single day.
Right.
So when hyaluronidase breaks down the natural HA, it is only a temporary localized depletion. The structural integrity of your skin relies on collagen and elastin, which hyaluronidase does not touch at all.
Oh, that makes sense.
Local tissue immediately registers the missing HA and spins its cellular factories into overdrive. It begins regeneration within 48 hours.
The body just ramps up production to fill the deficit.
Exactly. Within 1 to 4 weeks, the skin's native hyaluronic acid levels are 100% restored. There is no long-term damage, there is no structural compromise, and there is no permanent skin thinning from the enzyme. The clinical data over 15 years strongly supports this.
That is a massive relief. So what does this dissolving process actually look like on a timeline?
Well, we break it down into 4 distinct phases.
Right.
The immediate phase is from 0 to 30 minutes. This is where those biphasic fillers begin visibly softening, often before the patient even leaves the clinic.
Wow, that's fast.
It is. Then we enter the primary dissolution phase, which spans from 1 to 24 hours post-injection. This is when the most significant visible volume reduction occurs.
The structural wall is collapsing.
Yep. Then the progressive breakdown phase happens from 24 to 72 hours. Some heavily cross-linked monophasic fillers. The solid sugar cubes, from our analogy, they take a bit longer for the enzyme to fully penetrate and yield. Finally, the resolution phase occurs between 3 and 7 days. By the end of a week, the enzymatic breakdown is complete. The synthetic filler is entirely gone, completely wiped away by the lymphatic system.
Which brings us to the retreatment phase. By day 7, the filler is entirely gone. The slate is wiped clean. So let's say a patient had an intimate filler, they weren't happy with the symmetry, and they got it dissolved. How soon can a practitioner safely go back into that exact same tissue and inject new filler?
If we look purely at the biological half-life of the enzyme, it is incredibly short. In the bloodstream, hyaluronidase is deactivated in about 2 minutes.
2 minutes.
Yeah, but in the actual dermal tissue, its functional action lasts a bit longer. There is a fascinating study cited in our sources by Kim and colleagues where they tested this exact timeline on rats.
What were they looking for specifically with the rats?
They wanted to see exactly how long the enzyme remained hostile in the tissue. They injected an HA filler, dissolved it with hyaluronidase, and then attempted to re-inject new filler at various time intervals. They found that the enzyme completely loses its effect in the dermis within 3 to 6 hours. They successfully grafted new filler into the tissue just 6 hours after the eraser was applied, and the new filler survived perfectly.
Wait, hold on. I'm looking at the clinical guidelines from our sources right now, and something isn't adding up. If the lab data shows the enzyme is totally dead in the tissue after 6 hours, why are all the clinical guidelines making a patient wait 1 to 2 whole weeks before re-injecting?
It's a great catch.
Because, the coast is biologically clear by dinner time. Why the delay?
Because there is a crucial distinction between what is biochemically possible in a rat study and what is clinically responsible in human aesthetic medicine. The 1 to 2 week waiting period is absolutely non-negotiable for safety and aesthetics, especially in intimate areas. And there are 3 specific reasons for this.
Okay, let's walk through them. What's reason number 1?
The first is the risk of lingering trace enzyme. While the vast majority of the enzyme is deactivated in hours, any minute residual trace hiding in the tissue could partially degrade the new filler you just put in.
And that stuff isn't cheap.
Exactly. These cosmetic fillers are expensive and precise. You want absolute certainty the environment is entirely clear. You wouldn't pour fresh concrete while there's still acid on the floor.
That makes total sense. What's the second reason?
Tissue settling. The dissolving process isn't an entirely passive event. The body's immune system reacts to the rapid, localized breakdown of sugars. This metabolic rush causes reactive swelling, redness, and inflammation.
So it puffs up.
Right. The physical tissue needs time to calm down and return to its normal, uninflamed state.
Then the third reason.
The third is native HA regeneration, which alters the anatomical baseline. Remember that your body needs that 1 to 4 week window to replenish its own natural HA barrier that the enzyme temporarily swept away.
So if a doctor injects new filler into swollen, inflamed tissue that is also temporarily missing its natural volume, They aren't actually looking at the patient's actual anatomy.
Right, they are essentially flying blind. They have no accurate baseline to work from. If the penile or labial tissue is artificially swollen from the inflammatory dissolving process, the doctor might underfill the area, thinking it's larger than it is.
Oh, I see.
Conversely, if the tissue is temporarily depleted of native HA, they might overfill it to compensate for the missing volume. In either case, once the tissue naturally stabilizes a month later, the aesthetic result will be entirely wrong. Patients is required to see the true, stable canvas before you attempt to paint on it again.
So we know a 1 to 2 week wait allows the swelling to go down, the native HA to regenerate, and the baseline to return to normal, making retreatment safe. But if we need the baseline to be so perfect, how do we make sure we only dissolve the problematic filler in the first place without causing unnecessary trauma to the surrounding tissue?
That's the real challenge.
Because, as we establish, penile and labial tissues aren't just your standard skin.
Exactly. This highlights the immense danger of what practitioners call blind erasing. Hyaluronidase is a powerful tool, but it should never be used as a blind undo button.
Right.
If a doctor just injects high doses of hyaluronidase based on feel or guesswork, they might miss the encapsulated filler entirely. Or they might inject way too much enzyme into healthy tissue, leading to a massive, temporary hollowed look. You might resolve the complication, but you leave the patient with severe swelling and a new aesthetic deficit.
So how do you avoid that? How does a doctor know exactly where the filler is beneath the surface of the skin?
The game-changing advancement mentioned across all our contemporary sources is the implementation of high-frequency ultrasound.
Okay, let's unpack this. Because when most people hear ultrasound, they think of obstetrics, looking at babies deep in the womb. How does that apply to a few millimeters of skin?
Good question. High-frequency ultrasound uses a much higher megahertz range, which doesn't penetrate deep into the body, but it provides incredibly high-resolution imaging of the superficial layers of tissue just beneath the skin.
So they can see right under the surface.
Yes. Before the doctor even picks up a needle of hyaluronidase, they place the ultrasound probe directly on the intimate tissue.
What exactly are they looking for on the screen? Like, how can sound waves tell the difference between my natural tissue and a pocket of filler?
It's based on echogenicity.
Echogenicity.
Right, how sound waves bounce back depending on the density of what they hit. Because hyaluronic acid filler is essentially a dense pocket of bound fluid, it doesn't reflect many sound waves. It appears completely black on the ultrasound screen, which we call anechoic.
Okay, black on the screen.
The patient's natural tissue, muscle, and fascia reflect more sound, so they show up as bright white or gray. So the doctor can clearly distinguish between natural anatomy, areas of inflammatory swelling, and the exact dark pockets of the old HA filler.
It's like using a stud finder before swinging a sledgehammer at a wall.
That is exactly what it's like.
Instead of just tapping on the drywall and guessing where the support beam is, you use a tool that lets you look right through the surface. It turns a guessing game into a precise, targeted medical intervention.
Precisely. With ultrasound guidance, the practitioner can place a tiny microdose of the enzyme directly into the exact pocket of old filler.
They don't have to flood the area.
No, they use significantly less enzyme. They preserve the vast majority of the surrounding native tissue, they minimize the inflammatory response, and they ensure the problematic filler is completely resolved on the first try.
So bringing all this incredible science together to answer the primary mission of our deep dive today, can intimate HA fillers be safely retreated into the exact same tissue after being dissolved?
Yes, definitively.
Wow.
Thanks to the proven biocompatibility of BDDE cross-linked hyaluronic acid, the precise targeted action of the hyaluronidase enzyme, and the implementation of high-frequency ultrasound guidance, a patient can undergo full enzymatic resolution of a previous filler.
And then?
And, provided they respect the biology and wait that crucial 1 to 2 weeks for the tissue to stabilize and regenerate its native HA, they can safely receive a fresh, properly placed treatment in the exact same anatomical region.
It really is an incredible journey, just thinking about the mechanics of it all for you listening. How we take a natural sugar, build it to withstand the body using BDE superglue, how we can use an enzymatic eraser to instantly unlock it if a complication arises, and how our native tissue temporarily yields but quickly rebuilds itself.
It's biology at its finest.
It all comes down to respecting the biological timeline. Patience is the ultimate key to a safe retreatment.
The elegance of this system goes far beyond aesthetics, too. If I can leave you with a final concept to mull over, consider the broader implications of what we've discussed today. We've spent this deep dive talking about doctors using hyaluronidase to dissolve cosmetic volume.
Yeah.
But this same enzymatic technology, this precise ability to melt hyaluronic acid on command, is currently being researched in oncology and internal medicine.
Wait, really? How does dissolving filler connect to oncology?
It's fascinating. Many solid tumors actually surround themselves with a dense shield of native hyaluronic acid, which physically blocks chemotherapy drugs from reaching the cancer cells.
Oh, wow.
Researchers are now exploring ways to use hyaluronidase to temporarily dissolve that HA shield, allowing life-saving drugs to penetrate deeper into the tumor. They are also looking at using it to dissolve fibrotic scar tissue in chronic diseases.
So what we view as a cosmetic reset button might actually hold the key to systemic medicine.
The mechanism is exactly the same. We are learning to temporarily borrow, pause, and manipulate the body's natural extracellular matrix to our advantage. The aesthetic applications we see today are really just the proving ground for a much larger biological frontier.
So the next time you think about medical permanence, remember that your body is constantly hitting its own reset button, and science is finally learning how to steer it. Thanks for diving deep with us. Keep questioning, keep learning. We'll catch you on the next one.